Welcome, everyone. Thanks for joining us. I want to take a moment to introduce Christina Graves. She's from Adventist Health in Ukiah, California. So, Christina, take a minute to introduce yourself for us.
Hi, thanks, Marianne. My name is Christina Graves. I am a registered nurse that is the program manager for quality outcomes at Adventist Health Ukiah Valley. I've been in my current role for about 3 years, but I've been working as our sepsis champion for our hospital for about 7 or 8 years. So I've kind of seen us through our journey of our sepsis compliance throughout the years.
That's awesome. That's awesome. It's nice to sort of start at I'm going to assume sort of bedside sepsis champion through the organization, taking on a more of a leadership role, which is wonderful.
Yes.
So, Christina, today I want to talk to you about sepsis handoff tools and checklists. How did you get started with sort of wanting or needing a checklist or a handoff tool?
So as we've transitioned to electronic medical records over the years, it sometimes is a little bit harder to track the timing that's associated with the CMS sepsis bundles. So with our compliance, unfortunately, we were at the very low end of our compliance numbers and scale. So we had identified we had a large opportunity to help keep our staff on track with identifying sepsis. And really one of our things that we wanted to focus on was utilizing a tool that when we recognize sepsis on triage or when we first saw the patient, so the primary nurse sees the patient, utilizing a standing order set. So that tool allowed us to kind of use that as our time zero and move on, set our 3-hour time frame and our 6-hour time frame. So we would be able to track getting all of our labs done, getting our antibiotics in, getting our fluids into the patient. So that was a paper tool seemed the most user-friendly tool to use outside of the EMR system so everyone would see the same time. So we didn't all have different interpretations of what time zero was, what the 3-hour window and 6-hour windows were.
Got it. Got it. And so what do you think your first step was? Like, how did you pick a tool? How did you how did you introduce it to the frontline staff?
So the tool was actually brought to us by our system. We had a sepsis champion at our system level who was helping to roll it out. We just happened to be one of the first sites to get this tool. So we've had some opportunity to have some input on its different reiterations, and we wanted to keep it simple. So there's a lot of tools out there that we've seen other organizations use, and they're great tools. Ours is very simple. It's very streamlined, and I really feel like keeping it simple and streamlined really helps the bedside nurse, the bedside provider, just get to the nitty gritty of what needs to be done for that patient in the moment and trying to stay on track with meeting the timed elements.
Great. And who did you need help from, do you think, when you started this?
So definitely have to get provider buy-in. Number one, with our handoff tool, part of our process was implementing a code sepsis. And when we had that happen, you had to have provider buy-in, but then we also had to have nurse buy-in because the nurses needed to feel empowered to utilize our standing order set, grab the green sheet, use that, establish and feel that they felt empowered to establish a time zero themselves. So that was really helpful for us to use the green sheet, as we call it, our sepsis tool checklist, to establish a time zero and move forward with that.
Got it. Got it. So any tips and tricks on getting that engagement from your providers?
Well, it was a do or die. We had to get our numbers up, right? We couldn't continue being under 50% compliance. It's not good for our outcomes for our patients. It's just not good patient care. Really it was, I would like to say they came along willingly. Some of them had to be dragged along a little bit. There was some opportunity to write it into contracts to get help build compliance to help us with that. But the nurses really wanted to do what was right for the patient. So it was a little bit easier with our nursing staff to get their buy-in. And one thing I did forget to mention about who we needed to engage, we really had to also engage our sepsis liaison. So one of our biggest tools in utilization of our sepsis checklist is having a sepsis liaison, which is not just a person, it's just a role that can be filled either by a charge nurse or by our house supervisor. And what that person does is really helps assist that bedside nurse in her timing, or his or her timing of the care of that patient, and also allows them to kind of have a bigger picture focus on where that patient needs to land, whether they're being admitted to our hospital here or transferring. The house supervisor or the charge nurse are going to be integral in making sure that we're prepared to handle that patient later on in their care.
Got it. Got it. So it sounds like you were really using your compliance data to sort of drive your project. Is that?
Yeah. That is correct. We did use that, but we've also really looked at tying our mortality indicators to this number. While sepsis nationwide is a number one mortality indicator for many hospital systems, and it continues to be, we have seen the numbers decrease by our compliance and our best practices in use. And so we really tried to tie sepsis mortality numbers. Are we seeing them decrease? Did we do all of the elements, or were these fallouts? And when they were fallouts, why were they fallouts? And let's look at those steps and what we missed in the process. So that allows us to really use that tool to help drive our mortality and ultimate patient outcomes.
A little more real time, I would imagine, too.
Yeah, the other component of it that was really helpful is utilization of that. We are actually able to audit in real time. So within 24 to 48 hours of a patient presenting to the ER or inpatient staff, we are able to audit that chart and give real-time feedback on how our compliance was. So if it's a simple documentation issue, we can kind of just fix the documentation to the correct terminology that needs to be there. A lot of times we do great care, but we miss the documentation, as we know, in many of our cases. And so if we've done the good care, we just need to make sure we have the right documentation, and that's what that allows us to do.
I think it's critically important, as you mentioned, to tie your mortality to your process measures. For all providers, nursing, physician, everybody involved, it's like when they are constantly nudged about process measures, I think it's important to tie that patient outcome to it so that they connect the dots. It's important to connect the dots for everybody, I think, and you're doing a wonderful job of that. So when you implemented this checklist, did you use an improvement strategy? Did you PDSA it? Or were you given it from on high and this is what it was?
Well, I would say a little bit of both, right? We did know that this was a necessary metric that we needed to move. And so, yes, this is what we're going to do moving forward. We had a mandatory rollout throughout our ER and inpatient nursing staff and providers. So it was required training for all of them. But then we also PDSA'd it as far as were there areas that we could have looked at process improvement. And we did iron out a lot of the bugs in the system of the overhead paging system, of implementation of the green sheet, where the green sheet lives when it's done. And I call it the green sheet. That is our sepsis checklist tool. It's affectionately known as the green sheet here. And so we have one place that I'm able to, my team is able to pick up that tool and then use the audit to really dig into the cases and make sure that we're hitting our metrics every time.
Great, great. And have you seen an improvement with this?
Yeah, I mean, I think that with every good quality outcome that we see ebbs and flows in our compliance, and consistency is key. And so we're really revisiting, making sure that we're doing consistently the same work every time. And that's we strayed a little bit off the path the last few months, and I have a lot of efforts with my my hospitalist group and my ER group who are really trying to drive those metrics in the right direction and getting back to what we know works, and that is utilization of our sepsis checklist tool, our code sepsis, and our standing order sets.
Awesome, awesome. So if you could look back from today, your current perspective, look back on when you were first launching this, do you have any advice you would give yourself?
I would really have started from square one, making sure everyone had a clear delineation of what the CMS standards were. I think everyone had a little bit of different, as we know, CMS standards kind of change just slightly every year, every July with their new new metrics.
Mhm.
And I think even today, I just recently had a provider who was like, I didn't realize that hypotension also meant under systolic under 90. And I was like, well, yeah, it's not just a map of under 65. And they're like, that's what, is built into our orders. So it was a learning opportunity. So I think I would have gone back and made sure that everyone had a really clear education on what metrics and what standards that they needed to be aware of to diagnose and have that early intervention with our sepsis patients.
Good, good. So it sounds like that's the one thing you would do differently, is maybe more robust education around what the metrics are.
Yeah.
Yeah. And did you have any unforeseen challenges or wins that you weren't anticipating?
Unforeseen challenges, I still think that when you have a new provider is not understanding our process, obviously that onboarding effort is always a challenge, making sure that they know what's available as far as tools are available to them. Also providers who are a little gun shy or trigger shy of calling it a severe sepsis or septic shock. They might call it a cellulitis, a simple, and not actually use those words. But we know when we're talking about abstraction pieces that we really need to use those severe sepsis and septic shock when appropriate in our diagnosis. And so I think that those were things that were aha moments for us to go, oh, we need to be capturing those a little better and educating to that. Unexpected wins. I actually, we had some process measures that were put into place because of this implementation process that allowed us to really make sure that if a patient progresses that maybe does come in with a simple infection that's maybe on that road to progressing to sepsis, that we were capturing those blood cultures early on before we started any IV antibiotics. So we were already ahead of the game if they did see any other SIRS criteria that later on progressed, to be a more serious infection than anticipated upon triage or admission. So I think that was a win for us, is we had some processes around that and building in automatic orders of blood culture draws before giving IV antibiotics on most cases. So
Yeah, that's great. That's great. And what's next for Adventist Health Ukiah?
really hardwiring it. I think that's a challenge in any initiative, is hardwiring. And consistency is how you become a high reliability organization. And that's our goal, obviously, is to continue our journey to provide the best patient care. And that means doing the same care every single time for every septic patient that comes through our doors or through our ambulance bay in some cases. So I really think that we're on our road to seeing our compliance numbers. We sat at a high 90s for most of the year this year. And I think that we can get back there, and we're going to be there shortly.
That's awesome. Congratulations on all your work, and compliance of 90. That's hard to get with that score, that composite score.
Oh,
So congratulations.
thank you.
All right. Anything else you want to share?
No, I'd just like to thank you for this opportunity to share our process. And I hope this helps other organizations out there in their efforts to improve quality care.
No, I am sure it will. So I appreciate your time and your participation. That you've been wonderful to have as part of our team here.
All right. Thank you.